Right, good morning and welcome to the Health and Adult Social Care Scrutiny panel meeting for March. We have a couple of apologies, Councillor Richard Smith and Councillor Habiban Zaman, apologies. Minutes of previous meeting. Those have been circulated. Do we agree the minutes of the previous meeting? Yes, thank you. Are there any interests that anybody wishes to declare?
Yes, on item 4, just to say I'm a member of Locala. Thank you.
All debates are held in public, so we agree that the public can be admitted to the meeting. The item 4, podiatry services in Kirklees. This is a return to the scrutiny panel for Locala on their podiatry changes that they are proposing. Previously they came about their consultation. We looked at the consultation plans that they had, and this today is the results of that consultation and the recommendations they'll be putting forward to the CCGs. I understand you've a few little presentation that you want to go through it quickly. Has everybody got a copy of this? Yeah. Bearing in mind that we've all read your report, so if you just want to go through it quickly. If you want to as well, before you start speaking, say who you are, that will be good for us. Okay, thank you. So, Amina Hamzadeh, Operational Manager at the Community Partnership. So, podiatry consultation and recommendations. If you recall, we had two proposals that we put forward. One of them was to reduce the locations in the Greater Huddersfield area from 15 to 8. We've deliberated on the findings, and in the report that we've presented, there's further detail on that deliberation process, and in particular looked at items, areas around travel, etc., which was of a concern. Based on what people had filled in and the information that they'd given us. So we've had a look at that. We've done some further analysis on locations and travel, public transport, etc., which is available in the report. And our recommendation is that out of the 7 that we proposed to close, because one of them we had to come out of anyway, we proposed to close only 5 and leave Shepley and the Marsden open. And this was based on feedback from people within those areas and also the information that we researched around public transport availability and access. Okay. So in terms of recommendation 2, and this was around the criteria, eligibility criteria, so just a bit of background, it's been inconsistently applied across the service. Following the consultation and the findings of that consultation, we are recommending that proposal 2 be accepted and implemented. It's our intention to support, support and signpost patients to other provision that's suitable for those patients who do not meet our eligibility criteria. We have had some preliminary conversations with other providers that are available in the local area, Age UK being one of them, but until we have the go-ahead in terms of those recommendations, we'll firm that those providers up. I can go through all the slides. Would you like me to go through? Yeah. So we've just pulled out a few of the impact on the recommendations. So in terms of proposal 1, 484 patients will be required to access their treatment at an alternative provision, alternative location. And when we looked at the caseload, the current caseload, how many people that were affected by those locations, it was 932, which is about 4% of the overall caseload. Of those 4%, we further looked at how many actually used a different location anyway. And as you can see from the numbers there, 448 of those 932 already used a different location. So potentially 484 people would be required to do something different or access a different location. In terms of proposal 2, This information was extrapolated 18 months ago from the data in the caseload, and we've kept to the same data. However, what we've found is that 5,000 of those patients potentially may not meet the eligibility criteria. What we're proposing, though, is that everybody that comes to the service, when they come, will be reassessed to determine the actual amount, an actual number of people that may not meet that criteria. In terms of the impact on the podiatry service, by reducing the clinical sites, we will be reducing travel time, leading to more clinical time available with patients, improved resources at each site. So currently, an example is that at Princess Royal, we have to do most of our wound care work there. We would be able to do more of that work in other sites. And decreased need for carrying equipment that we have to have with us to do the treatments that we do. In terms of the impact on eligibility criteria, there'll be increased capacity for patients with the greatest needs. So we're seeing an increased caseload of complex patients who are further on in their conditions, etc. Safer service for those with foot ulceration and the need for foot protection follow-up, and improve action times for emergency referrals. And then on the last slide, we've just put together a draft plan of implementation around communication and awareness and training, and obviously this is subject to any sort of suggestions, etc., and anything that comes out of today that we may not have considered. And that's all.
All right, thank you very much for that then. We'll move to questions then. Dave?
Yes, it's just on the recommendations, which is page 22 of our report. On proposal 2, there's a list there of alternatives for those who will no longer get the Locala service. Just wanted to make the point that it might be useful to perhaps think in terms of having a leaflet available which outlines those possibilities, or perhaps a page on the website. But specifically on the Age UK proposal, it mentions there that there's an agreement in principle from Age UK and that you've got a 2 to 3 month mobilisation period. It's just that concern that if you implement the findings of the consultation before that service is available, there'll be a gap. So could you comment on whether or not there would be a gap?
There wouldn't be a gap because everybody that comes to the service will be reassessed. So they'll have that treatment that day as well as that reassessment. So if they're not eligible, they wouldn't require treatment till another 3 months. So within that 3 month time, the new service or whatever's in place will be available. Does that answer your question?
Yes, it's just that it does say agreement with Age UK in principle. So how confident are you that the service will actually get provided?
Hi, I'm Lisa Butland. I'm the Chief Exec of Age UK, Calderdale and Kirklees. So we've been having discussions. Age UK have a model for nail care services, which we've already piloted in Calderdale. So we've got the experience of setting the service up from scratch. We'll be looking to identify a number of sites and roll it out over a period of time, but we would feel confident that we'll be able to get some services up within the 3 months.
A number of points, please. I mean, just to follow up on that, is the transfer of care to Age UK, is that cost neutral to yourselves?
We're in discussions about how we can support Age UK to do some of that quickly, and that could be funding some of the locations that we're already in. So if we're coming out of some of those 5, we've potentially already paid some rental fees, so they would be able to use them on our behalf. So cost neutral, we may invest a little bit to support with instruments and things like that, so that it is seamless for patients.
Right, so it's start-up costs and then the cost transfer to patients. I mean, the substantive points, Liz, if I may. You say that the improved number of locations, the reduced number of locations, will give an improved quality of service, and I don't think we would dispute that having a critical mass of people in the right place is absolutely logical. In terms of quality, how are you going to measure that in terms of clinical performance or in terms of performance measurement? How are you going to? Because for the public, this is not about cutting toenails; it's about cutting costs. So how are you going to say, well, look, what we do has got a lot better?
Wellbeing Services, which podiatry falls into. Part of the performance framework that we'll put into this is we'll be able to measure the complexity of patients that are seen at different sites, because at the moment there will be some patients that can't be seen at every site because of the skill sets there. We need to make sure that we have the right skill set. We've already got a performance framework in place. What we'll also be able to do is to measure the waiting times for our very complex patients. And we'll also be able to see them more frequently if required. There isn't any cost cutting, it's about utilising those resources that are needed for the more complex patients, which then in turn avoids any hospital admissions as we're able to see them more timely. Does that help?
Thank you. Yeah, thanks, that's helpful. And then just to move to your eligibility criteria, which I think you told us previously they're codified by NICE, or are they?
The eligibility criteria, and Paul, you might have to come in on this, has been around and agreed by West Yorkshire podiatrists. So it was done 15 years ago, possibly now. The NICE guidance element is around the conditions that affect the feet and how to look after those conditions. So the two together do sort of create that, the matrix has been developed from that. So say, for example, patients with diabetic feet, there is a way to look after those feet recommended by NICE, and the criteria, the matrix encompasses that.
Yeah, I understand the clinical problems with ulcers and with diabetic and vascular and rheumatic, and understand the pathology side of it. But going back to the criteria, something that was devised 15, 20 years ago, I mean, is that evidence-based? Sorry, just to add a rider, that we've got a much older, more infirm population and fewer people who can get down to actually cut their nails.
Paul Cotton, podiatrist, clinician. Evidence base in podiatry is poor. There's no doubt about that. There is no evidence, to my knowledge, around giving someone without any risk to the foot a service is going to prevent problems in the future. Common sense might say it would, but there's no evidence to say it would. There is evidence to say that if you concentrate on high-risk patients, on high-risk diabetic feet, arterial problem feet, there is evidence to say that this reduces hospital admission, reduces the incidence of diabetic foot ulcer and foot ulcer generally, and certainly reduces the incidence of amputation.
I think what I'm getting round to is whom would you turn away?
Okay, the criteria is, if not eligible for podiatry services, any person who has no medical or podiatric need, including those that cannot self-care. Non-pathological nails where no risk is present. Non-pathological callus or verruca where no risk is present, no medical risk is present. People with diabetes that are assessed as being low current risk in accordance with NICE NG19 with no podiatric need. So they're just coming for nail care, but they're low risk diabetic. So in essence, no more risk than any other member of the public. And asymptomatic development paediatric conditions, i.e. curly toes, flat feet, none of those would be eligible for our service.
So, what about GPs who, by their nature, will pass people on to you to get rid of them? What are you going to do? Are you going to?
We'll accept the referral. We'll assess the patient, and then we'll accept them into the service or discharge them from the service with options of where to go for routine low-risk care.
Can I just come back on your health need criteria? Does that include people who have mobility problems, who cannot manage to look after their feet because of any mobility problems whatsoever?
No. The health need, the medical need, is purely on a risk to the foot. Arterial, neurological, maybe the medication they're taking, high-dose steroids, etc. So we can't take mobility into consideration purely because the vast number of our patients have mobility problems. Moving forward, it's going to get greater all the time. The fact remains that the only problem with the foot is more of a social problem, i.e. they've got long toenails. If there was a risk to the foot caused by circulation, neurological conditions, then yes, they'd be accepted into the service.
So, sorry, let me just get this right. So people with mobility issues, somebody in a wheelchair or unable to, for whatever reason, be able to not get to the feet, to be able to cut their nails, we are saying we would not be able to provide that service for them completely whatsoever. I'm just kind of really concerned because there seems to be so many things that are happening in terms of cuts into the other social care funding, that what happens to that patient, what will happen, and if from this point of view it basically says, well, it doesn't really matter, and that doesn't sound right. I understand totally that you want to kind of just focus around the feet, but surely it's quite obvious that if they had genuine difficulties, mobility or something like that, it wouldn't be possible for them to do, and I just think that you should have included that in there.
If we include people with mobility problems, we're probably including everyone over the age of 80, or a high percentage of people over the 80 that can't literally reach the feet. And that's where we are now, basically. And we've got to concentrate on those with the highest need to prevent problems. We hope and expect that people with mobility issues and no real need for the service will be, the nails will be cut by family, friends, or the other proposals that we're putting forward, Age UK, the university, or ultimately private provision.
So on proposal 2, the 5,000 people that don't meet the criteria, could you give us a breakdown of roughly what you anticipate in terms of your 22,650 caseloads? What is the criteria from that, the 5,000 people that have come off, that you potentially think will no longer be able? What is that there? Because we don't seem to have any information on that.
The 5,000 are people that won't meet the criteria, so have a low medical need and a low podiatric need.
But no breakdown has been given as to why and what the... it would have been nice to have some kind of breakdown as so we get a bit better picture as to what's happening here.
Can I just follow up on this? So there's no consideration of levels of mobility, because when you say family and friends could perhaps do it for you, are you really going to want to ask your friends to do that? So if you have a certain level of mobility. There's no consideration whatsoever as to degrees of mobility. That's what I'm not really asking.
We've not taken mobility into consideration at all, as haven't, and we've very much based this on the Sheffield model, and they don't, and a lot of other areas around the country don't take mobility into consideration. It's purely the risk to the foot and the need, and the actual need for podiatry services.
And have you looked at people who are on their own and how they're going to manage? So if you've got mobility issues and you're on your own, how are they going to manage? And also, what about, can you clarify what happens about housebound visits? What will happen about housebound visits on this plan?
Housebound visits will be given to those who are housebound and meet the criteria.
In terms of the in terms of the patients that are on their own, one of the reasons why we are working with Age UK is because that is the gateway to further sort of support and social support that can be provided or accessed by those patients.
So can we just clarify then, please? Housebound, you've got to meet the criteria still. So the Age UK service, will that be a service that will both be in clinic and for the going out to visits for housebound?
No, it won't. It'll just be based in clinics initially.
So the person who's housebound is housebound for mobility reasons or for whatever other reason, not necessarily the fit reason, so they don't fit your criteria. So basically what you're saying is that we won't be given the, you did mention private care. It's easier said than done, but obviously in terms of austerity, those things that haven't been considered enough. I mean, going back onto your page 24, where you've roughly given indications of how much it costs in a taxi to get there. I find it quite shocking that you've put taxi fares as in Uber calculations and not Kirklees calculations as Kirklees taxi fares.
Kirklees taxi fares were way higher than the Uber fares, and not the ones I found were, in my opinion, not in context, because I know what I pay. I live locally. I know what I pay, and the Kirklees taxi fares were way above what I usually pay.
However, to get an Uber taxi, you need a smartphone. So these people who are potentially elderly generation who are not using a smartphone have not even been considered. I find that is something that's you've literally not considered whatsoever. You'd need to be quite savvy to be able to get onto Uber, and there's also the potential national issues around Uber themselves.
Uber was just used as an example of prices. Uber itself, I'm not saying people have to use Uber, it was just an example and a way to find taxi fares.
Yeah, I think the point is that Uber is known to have lower fares, but there are all sorts of other issues. And as my colleague has said, you actually need a smartphone to use Uber. So it's a bit misleading, I think, to use Uber as a price indicator. I can understand why you've done it, but I think it's misleading. I wanted to raise a point on the same page 24, which is to do with access to the Meltham surgery from Marsden. Now, I appreciate it's not so significant now because you're going to keep Marsden open, but there is a comment there about the frequency of buses from Marsden to Meltham. And this is a detailed point, but I just wanted to raise it that you refer there to the 335, which runs from Slathwaite. You have to get from Marsden to Slathwaite, then get the 335 from Slathwaite to Meltham. That bus is only hourly. So there is a connection issue there, which might be significant. And the other bus you mentioned there is the Pennine Community Transport 938, which is pretty infrequent. I can't recall the frequency off the top of my head, but it's a local community-based service, but it's not that regular. So just in terms of thinking about access from Marsden to Meltham, it's a bit more time-consuming and complicated than is indicated here. Although I accept you're keeping Marsden open for the time being. So, yeah, that's good.
Can we just ask about, well, your report on page 20, clinics should be located closer to home, and you've said home visits would be available for housebound patients, which is why I asked the question about housebound patients. So that needs qualifying in that it's housebound patients who meet the medical need, is what you're saying. But on the bottom of there, it gives the locations proposed for closure. And we appreciate that to Marsden and Shepley that you've changed what you're proposing for there. Can we just explore that Honley and Newsham? You've got a large number of appointments in those clinics with a high, those two I think are the highest that have patients using the locations. So have you done any assessment of whether they are clinics that are being used because of their certainly Newsham because at Princess Royal because of its location, with people being able to access more easily those clinics, as to whether they are people just from the area or whether they're people coming in from other areas who are accessing those clinics? And how are you going to be able to disperse? Well, it's over 1,000 appointments between those two sites. So how are you dispersing those appointments across the other clinics that you're proposing to have in use?
The idea is to increase the number of sessions in the clinics that we're keeping open to the same level that we have now.
So to clarify, at Honley and Newsham, particularly at Newsham with it being at Princess Royal, your assessment says there's a bus past every 20 minutes, and from Golka you can get one to the door from Golka. So have you done any assessment as to those patients that are using those locations, whether they're just from the areas around those locations or whether they're coming in from other areas because of the accessibility of those locations?
We think, and I can't confirm this right now, but it'll be mostly people that are from that area. Usually the people that go to these practices are patients of those GP practices.
Yeah, I just wondered, for those on low incomes such as universal credit or pension credit, is there any kind of passporting for those people who would then be able to claim back the cost of privately provided foot care?
Not that we're aware of. I'm not aware that that's available for anything related to health. I don't know if you know.
Does anybody have any more questions on this?
Yeah, thank you, Chair. Liz picked up on it about the total number of appointments at Newsham Surgery and at Honley, and it was just really just about the time and the frequencies. So we're looking at between 12 and 20 minutes. I think maybe the timings and the buses could do with some work on, because the 307 passes my house, and I've never seen it every 20 minutes or every 12 minutes, so that might be a discrepancy there. I think 307's every hour or every other hour, and they are, the bus time, these are only as good as the frequency of the buses. The buses, you guys aren't in control of that, but up Sisset Dearne Valley, 8 minutes, that's nearly beating London Underground times.
8 minutes is the time from A to B. And it takes 8 minutes, and it's every 20 minutes. These are from the well-known Google.
So can we just clarify then, for everybody who's going to the Newsham Surgery at Princess Royal, and you've got over 500 appointments currently there. You're asking them to go from a 12-minute journey every 20 minutes to a 35-minute journey with 2 changes. That's what you're asking them to do.
Remember, it's 500 patients or treatments? 500 treatments. They probably have 4 treatments a year, so that's just over 100 patients.
Yeah, well, it's for Newsom, you've got 190 patients. So I was presuming there was more than one, more than one appointment. But you're asking those people to go from a short journey to 2 bus changes.
Looking at the number of times they come a year, they probably won't meet our criteria for entry to the service, because people with a higher need come more often.
Yes, but if your future, what I'm sort of getting at is if you meet the needs, so for those who meet the need now and for the people in the future, you're asking them to do a 2 bus service change journey from what is now a 12-minute journey every 20 minutes. That's what I'm sort of, how have you worked, what I'm asking is how have you worked the criteria out for distance for these? Because that, to me, sounds quite a big difference.
The distance is from the existing clinic to the new clinic. So it takes no reference at all to where they actually live. And remember, they might need to take 2 buses to get to Newsham anyway. This is from clinic to clinic, because we couldn't do it any other way.
And a large proportion of the people completing the questionnaire travelled by car, 47%. Yeah.
I'm asking for the people who don't travel by car. Yeah, okay. Peter.
Sorry, just a small point, please. And again, I'm coming back to the frail elderly and the people whose mobility depends on being able to walk, either being able to walk to the toilet, being able to walk to the kitchen to feed yourself, or possibly being able or not able to get to the bus. And I just wondered what you were doing about, I mean, given that we understand that a sophisticated diagnostic position needs a qualified clinician, and that you don't want to be doing menial things. But what are you doing other than Age UK, which we would welcome? What are you doing amongst the many other professionals who go into people's houses to make sure they're able and equipped to deal with some of these grossly thickened and deformed nails and the sorts of pathologies that you would see? You know, who else is going to have a go at this?
Grossly thickened nails, grossly thickened would meet our criteria. It's very difficult to quantify what's grossly thickened to the general public and what's grossly thickened to a podiatrist. Are 2 completely different things. You know, we're talking 5, 6, 7 millimetres for grossly thick, not 2, 3 millimetres, which is what the general public would say, oh, they're really thick.
Sorry, I mean, the exemplar may not have been perfect, but people who, I'm really asking the question about the other people, the care assistants, the nurses, the various other, the physios, the various other professionals, the OTs, who go into people's houses, and the problem is, it's me feet, love. And whereas historically it would have been possibly quite legitimate to say, well, we'll get you the podiatrist. You're not going to be there anymore. So, you know, can somebody else not have a go at cobbling these toenails? Is my.
If it was regarding a complex condition that would meet the criteria, no, that would have to be dealt with our podiatrists. I understand, and I seem to recall that from the recent tender that went out for domiciliary care, there's an element within the new criteria going forward that included an element of nail care. So if that person had been assessed and required support at home or, you know, with daily tasks, I think it was called nail filing, but I would have to revisit that contract detail to be able to confirm that. But I'm 90% sure that something was included on those lines. Which would then, for the people who are housebound, and are not, who don't qualify the criteria as per from the clinical point of view, but they do have carers going in to look after them, that should fall within that contract.
I think it's concerning that we've got so far down the line that you're not, you're going to have to clarify that, because I would have thought that there would have been conversations already with social care and other agencies as to the impact that could be felt across the system of changes, because there is now, isn't there, more of a health and social care approach to services, and therefore I would have hoped that there would have been conversations as to the impact on other service providers as to any changes that are happening as to how that. So that does concern me. Does that, Julie, you want to come back?
Thank you. I'm Julie Stewart-Turner, Chair of Scrutiny. So I've just come to observe today, but you're talking about news and surgery, so I just have to chip in, because I'm a news and war counsellor. And I've just heard some contradictions in what you've been saying, which is starting to unsettle me. I wasn't unsettled till I sat and listened. But you talked about the news and surgery, and you said the majority of the patients that use your services will be patients of news and surgery. Well, they will only need to get one bus to get to news and surgery. There's no need for anybody to get two buses to get there. You've also said the vast majority of the people that use your services will have some mobility problems. That is why you cannot take that into consideration as part of your criteria. Now you're asking these people that live very close to the surgery or only have to get one bus to get two buses to get to Princess Royal, or one bus and a very steep and awkward walking route. It just doesn't stack up to me in what you've been saying.
We need to summarise, I think. So if I summarise, and then if the panel wants to make any further comment as to concerns that I may have missed. Okay. So I think overall we have concerns about the proposals. We recognise that you've put in, you've looked at what was said in the consultation, and you've put in your recommendations 2 clinics back in that you're not going to ask for decision on. We recognise that you've done that, but I think we need further work on the impact for some of the other areas. It does concern me that you're not certain of the patient profile of the people who seem to be going to central locations. If they're all from the GP surgery, then you're asking people to do a greater journey than what they have at the minute. But you're asking people who, by what you've said, may have mobility problems themselves. So that is of concern. But I'm wondering if when you're looking at these recommendations, and certainly I would ask the CCGs to look at this as well, that mobility levels to be considered in the proposals for who can receive a service, and also that the Age UK service needs to be in place before any Locala service is removed. But one of the greatest concerns is those for people who are housebound. This seems to be an effective removal of service. If the Age UK service is not going in to do home visits where the Locala service currently does them, and you're saying if they don't meet the need, then they won't get those home visits, then that is an effective removal of service for those people. And therefore that would give us great concern that you are effectively removing a service from people who are housebound with no conversations, or seemingly no conversations, about how a service could be provided to those people. Okay. Are there any other concerns that we would like to raise?
Sorry, just around just a travel plan really, because again, I know Honley and Newsham have a high number of appointments, and asking to change to go on to 2 buses is, in my opinion, is a significant change, and all it takes is a bus to be 3 or 4 minutes late, an elderly patient getting off the bus and getting into the clinic. They might set off at 9 o'clock, their appointment might be at 11 o'clock, they might not turn up there till 11:30. So what impact will that have? They'll miss their appointment potentially. So if we could look at, in a bit more detail, the actual, the reality of the travel plan, because 2 buses is, in my opinion, is a significant change. Thank you.
So the costing is not a budgeting issue, but cost obviously is included in all of this that happens. There seems to be an awful lot of people that are going to lose out, 5,000 people, and at the moment it's certainly not clear from the way you produce the paperwork to show us that the 5% caseload or work difference that you're doing is anywhere justifiable for that 5,000 people.
So I think we really need more clarity on the caseload as well. Okay, so those are the concerns of the scrutiny panel. We would ask that those concerns are addressed and that we receive feedback on them. Richard, the officer, will be in touch with you as to timescales for that. I think we would need this pretty quickly because when are you going to the CCG for decision? When are you going to them for decision?
We've been to joint overview and scrutiny, or not overview and scrutiny, joint clinical quality group already. A meeting to decide yet to be arranged. We needed to come here first. Yeah.
And we'll also pass our concerns on to the CCGs, asking about the services that we're concerned about, and that the Age UK service needs to be in place before any service is reduced, but especially about people who are housebound and the mobility levels to be considered in the criteria. Okay? All right. Okay. Thank you very much for coming today. Thank you. Okay, this is the Adults Care Offer consultation. Officers from Adult Services are here, and also I believe you've got somebody from the companies doing the consultation as well on behalf of the council. So we've read the reports through. We had yesterday the consultation draft. Thank you very much, and we've had a look through that. So are you wanting to say anything before we move into questions?
Okay, so this sets out our intention to go out to consultation around the adults care offer. So members will be aware that we've talked about a shift towards a strength-based way of assessing people in need of social care support. What we've done is a lot of work with our practitioners around how we shift the way that we assess people's needs, and that's to factor in how their needs are met through family and friends and community available resources. As part of doing that, we've reflected that we need the tools that the practitioners then use to determine the budgets that people get within which to meet their care needs, the tools around direct payments that allow greater flexibility and choice to be fit for purpose. So they've come in scope into this consultation. A key decision notice has been published to go out to consultation. So this today describes the methodology about how we're going to engage both with service users, future service users, other stakeholders, including providers and health colleagues, around our intentions to move this forwards. If I just pass over to Mark, he could say a few words about the methodology. Yeah.
Yes. Hi everybody, my name is Mark Uden. I'm a director of an independent consultation organisation called Public Perspectives. We specialise in conducting research and consultation with the public and charitable sectors, and we've got a lot of experience conducting adult social care and health consultation. And we're on the Kirklees Council consultation framework, and we were commissioned after a due process. We've been commissioned to provide a degree of independence to the consultation process and obviously expertise and support. The consultation is focused on identifying levels of support or not for the proposals that have been outlined by Amanda, and also in particular the potential impact they could have on service users and prospective service users, as well as provide an opportunity to help improve services and outcomes and reduce impact, but also ultimately deliver positive outcomes for service users. The method, which I understand has been outlined a little bit in the paper that you've received, is several-fold. We're trying to provide various opportunities for service users and prospective service users to engage in different ways. So there's an open access consultation form, document, questionnaire, which is a draft version of what you've seen and have in front of you, and that's available predominantly online, but also available on hard copy as well. And there will be an easy read version of that too. There's also going to be a targeted telephone survey with 250 prospective service users, so we'll be targeting people aged over 55 and people with disabilities to assess or give them a chance to input into the consultation and give wider reach and greater representation. We're also conducting a series of focus groups with current service users as well, and we're also conducting consultation with a variety of stakeholders, community organisations, providers, and in addition, staff are being engaged in the process as well as frontline practitioners to understand their perspective in addition to that. Just worth stating, the document you've had in front of you is in draft and it will be finalised pending the discussions today, including scrutiny, and we're culminating an independent report. The consultation at the end will culminate an independent report which will be used to inform your decision making.
Thank you. Can I just have clarity? You're saying about a minimum 250 telephone interviews will be undertaken. Will that be spread across Kirklees area? So it'd be random sample, but you make sure it's across Kirklees?
Yes, absolutely, yeah. We will be setting something called quotas, which will make sure that it's demographically representative of those target groups that we're aiming to target, and it will be very much spread across Kirklees. And we'll be able to do some fairly basic level, but some geographical analysis there to see if there's difference between north and south of the area.
And also, you haven't mentioned any translated copies of the consultation. Will you be doing any translation copies?
Perhaps colleagues might be able to answer that. Certainly what we can do and what we actually should put into the document, which I think we'd always intended to, in fact, is say on request we can do translated versions. I think we did talk about that, and Amanda, you may have...
Hi, yeah, we built that in, so on one of the more recent documents it says that alternative formats including different languages are available on request.
Thank you. Now we do have one or 2 points, especially on your questionnaire. So I'll open it up for questions then. So Priscilla and then Dave.
Sorry, and there's an easy read kind of a version coming out. It would have been nice to be able to have a sample of that. Clearly this piece of consultation looks okay for us Kirklees officers or somebody who's probably been engaged with what's going on in terms of adult social care and things like that. The average person on the door or the service users is not going to be able to understand this language form whatsoever. So I think a serious consideration is required to change the actual language we use to be able to communicate with people, because just if you look at some of the questions here, you're not going to be able to engage with the normal service users. I'm not, not saying anything about anybody's level of understanding, but it needs to be broken down to basic ways of how they would be able to understand what's going on. Strength-based approach. What's a strength-based approach for an average service user? They wouldn't know what that would mean in the context of adult social care. They would just be understanding how it would mean for themselves. So just a bit of understanding. Though I understand you said that the language, so I'm going to the second point, that the fact that you'll say language, you can have it in different formats of different languages, only available on request. Kirklees itself, it covers a lot of people with a lot of backgrounds, and not necessarily they would know how to ask for these. So having these widely available would be would be a plus point, and also the fact that if you could do something more social media wise to get more people to kind of engage with being able to have an access, so like a service monkey, you know, like a questionnaire, doing it in small chunks with a bit of a narrative or a video to be explaining what you are hoping to do, then you might actually get more people engaging with you, because this way, as it is, we rarely get people kind of wanting to fill out any questionnaires. Anybody does, really. So being able to want to do that. Sorry.
So I think that was the intention around doing the focus groups, was to really be able to engage on a deeper level with people than we're able to convey in a survey. We've taken the challenge around the use of any jargon and acronyms and things, and tried to explain things, but we welcome any feedback where you think we can get some further clarity there. I think we've steered away from producing lots of printed materials, but I will take away that message about how do we get upfront and clear to people that they can request in different formats and languages. I think that's a really valid point. We'll take that forward.
Yeah, I'm not really sure what the purpose of the consultation is, or what you're trying to get out of it. In other words, what is actually changing? There's a reference to a strength-based approach. I don't understand what that is. As far as I can see, I mean, you mention on the second page why you're doing it, which is really because of there's less money available. So I'm assuming that means that there then needs to be a focus on, if I can use the phrase, more serious cases, because there's less money. But that doesn't come out in the consultation, and it's hanging it around the strength-based approach. It's really not clear what that is. I mean, my impression is that what you're saying is that we want to have the money to help necessarily, so there'll be more self-care and there'll be more use of community, local organisations rather than the council service. But it doesn't come out like that. There are some specific questions which it's clear about. So should you be able to use direct payments for holidays? Should you be able to use direct payments for family members to provide support? But overall, I'm not quite sure what the purpose of the consultation is.
The outcome of the consultation is that we will be revising the current resource allocation system, so that will be a change in the amount of money that we make available to people to meet their care needs. And that change is on the basis that we will have a different conversation which looks at needs that are currently able to be met through their informal carers, through resources that are available in their local communities, and it's for us to be explicit about that shift. But I take your point that perhaps we need to revisit that section that explains the strength-based approach, so that it's much more clear than we've currently got. So we'll take that as a way, as an action to do. In terms of the changes around that, we haven't currently got a direct payment policy, so we will be introducing a direct payment policy. The purpose of that is to be able to, moving forward, have a more flexible approach to achieving people's preferred outcomes. And the hypothesis is that we will be using resources in a much more efficient way to get better outcomes, but perhaps for less spend. So we'll take on board your feedback and re-look at those sections to make sure that that's explicit. But I think it's quite a complex subject, really, to communicate, and that's the value of having some focus groups in there, is to be able to have that dialogue and for people to be able to seek clarification.
So a significant part of this is changes to the resource allocation process. But there aren't, as far as I can see, there aren't any specific proposals as to how that would change, how the resource allocation process would change.
Okay, so the resource allocation, as we do have a resource allocation system at the minute, but when we use it now, what we're aware of is, despite having this, which gives an indicative amount of money from which to plan your care and support, there are massive variations in practice. So we have a lack of consistency in terms of the outcomes being achieved for people. So the changes in the resource allocation system, the process is going to be much the same. It is the formula that sits behind will be changed to build on the learning we've had from the previous resource allocation system, or the current one. And in building on that, we'll refine it so that at the moment, it may be that somebody has a need for which we allocate an amount of money for them to meet that need, but in actual fact we have, for example, an assistive technology offer that will meet that need. So we are double funding people. We're saying, here's an amount of money to meet that need, but actually you don't need it because we've already commissioned assistive technology. And I think that's very confusing for people, because on one hand we're giving them an allocation and on the next we're saying you don't need it. So we're taking the learning from that and refining the resource allocation system so that it's much clearer as to what the money the money's being allocated to meet, and what we expect you to do in order to meet other needs that need to be met, but might be met through the Community Plus offer, through an assistive technology offer that sit outside of our resource allocation system.
Chair, if I could just perhaps add to that. I think part of the challenge that we face is that there's often a confusion between the payments that people receive through DWP and the resource allocation system. So people are clearly entitled to things like attendance allowance, disability allowances, and we clearly work with people to maximise those. With the resource allocation system, one of the things we might find is that we have two individuals, one of whom has got a lot of family who live close by and another of whom doesn't have very similar needs. Currently, we'll have a conversation with each of those individuals and we'll identify through our resource allocation system that each of those people would be entitled, in inverted commas, to receive £100 worth of support from the council, to pick a figure. But actually, for the individual who's close by, once we get into the conversation, discover that they have family members who are willing to provide support, the family members might need a break. Actually, that individual doesn't need £100 worth of council support. But then the confusion with the DWP system comes in. So people think they're entitled to £100, as they would be through a DWP payment, but we're now somehow taking that off individuals. They didn't need it up front because at that point in time their family members were willing to support them. The other individual who doesn't have family nearby may well need all of that resource because they haven't got anything else they can draw on. And we're trying to find a way of being clearer up front about the sorts of things that people can draw on before we get into a conversation about the money. Because as soon as you have a conversation about the money and then move into the things that would help resolve something for an individual, so family support using assistive technology, to the public it feels like we're taking something off people and we're trying to kind of just flip it around.
Can I, what you were saying about met and unmet need and all this, that's what this sounds like, right? Complicated. And I know it's what you're trying to put over is complicated. So I appreciate that it's difficult to make that. But your general direction as well is I don't think we're struggling with the general direction of where you're going from what you're putting in your consultation document, okay? And I think we'll go through it page by page and we'll bring in comments. But what you've explained there about the different needs, maybe that's something in your explanation about strength-based approach that you could put more case study information in there to make it a bit clearer what you're meaning, because you're using terms like resource allocation system. Well, who outside of the council knows what your resource allocation system is? Yeah. So I think it's the language that you're using, but also the practical. And one of the things I'd written was, well, who should complete the questionnaire? The first thing somebody's going to ask is, how does this affect me? And you need that up front as to, right, okay, if you need to complete this questionnaire, if you're in receipt of this, if you're doing this, and everything, you need to be clear as to who you're aiming at, and also, does this mean I will lose what I currently have got in terms of support? And you need to be reassuring about that. If it doesn't, then you need to say that. If it may have an effect, then you need to say it in what regard. I think the language is very thick. I think that, and you need to be clear as to who it affects, how it may affect, how it may not affect, and who should complete the questionnaire. And you're saying about focus groups. Well, yes, but that's with people who are presumably currently in receipt of service. You're also asking future service users. And how are you going to do that explanation from focus groups with people who may be future service users or family and carers of people who may be thinking they may need service in the near future? I think it is complicated, but you need to be clearer, I think. I've got Peter and then David, and then we'll go through each page.
Sorry, I'd started to go through it, Liz. Just to come back to the point that Dave was making, please, about the strength-based assessment. And what I wondered if I were a client is I'd be asking myself, how reliable and valid is this process? Very, very dependent on the very worthy professional judgment of probably a social worker or whomever. But would one social worker see it in the same way as another? And how are you going to validate these decisions, particularly if the recipient is unhappy or the family are unhappy? So really that was the question. How dependable is it?
So we're doing a lot of work with our social work practitioners and the community support officers around achieving consistent practice in our assessments. We have intelligence and we have quality performance and resource clinics that look at how do we use resources, what's our consistent offer. We do case file audits, we have supervision, we have a process for signing off the allocation of resources so that we get that challenge that we can always see the service user's voice in the assessment and what they prefer, that we can see how resources are being deployed as a way of having consistent practice.
So will it materially change things if you manage to implement this in the way that you hope, in terms of quality of the service that people will get, and I suppose more important to you, will it improve your bottom line position?
Okay, so the intention is to address the variance that we've currently got in practice and care packages across all cohorts of people. So the intention is to get more consistency through the refined allocation system and through practice changes. I think one of the other intentions is that through the direct payment policy is to have more of a framework about how we use direct payments, because we've seen a lot of variance in how we use those, which doesn't, it's very difficult to explain to people with the absence of a policy what our approach is there. In terms of is it going to make a difference, it will make a difference for some people. Some people will see a positive difference because our intention to use professional judgment and to have more flexible ways of working to achieve preferred outcomes and to move away from that traditional approach to menus will be a positive difference. There will be some people who see their resources reduced because as we refine it and we start to say, actually we gave you an allocation to meet this need, when in fact, so for example meal preparation, but actually you've got a household member who's doing that for you, so you didn't actually need an amount of money. That will make a difference for that person. But it won't be that we just have a day when everything changes. That will always be undertaken as a conversation on a one-to-one basis so that people have got an opportunity to raise any concerns around the impact it'll have on them.
Yeah, I was just going to use question one as an illustration of the difficulty of consulting in this way. So question one is about making more use of community support, families, friends, etc. The way it's written, I'd be very surprised if people don't agree with it. It's like, do you like apple pie? The big question is, if you have more support in that way, as you've just illustrated in your example, it might mean that you get less of a direct resource through your direct payment from the council. But it doesn't say that in the question. It doesn't say if you have more support from your community, family, friends, you might get less support monetarily from the council. It's a kind of, well, yeah, this is great. I agree with this. So I'm not quite sure how you can extract any meaning from the answers to those questions, because most people, I would have thought, are going to be in favour of it.
We'll factor that in. We'll revisit that question.
Okay, so, right, let's go through it then, because I'm sure we've got comments. So your first page of your consultation document, I think we've sort of pretty much covered all of that about the language and the strength-based approach, knowing what that is. At the bottom paragraph of that, then you find, we're also developing our approach for direct payments in the middle, at the end of your strength-based approach. And I think you should be clear at the top that you're looking, this is two things you're looking at. You're looking at your changing to your new approach, and you're also affecting direct payment policy as well. Do you know what I mean? Because that just looks as if it's a bit of an afterthought there, by the way, which is where I'm coming from as well with who should complete the questionnaire. Okay, yeah? Right, any other comments on page 1? And page 2 then. You're asking about people aged over 65 is expected to grow. That's very prescriptive in the age, and I realise it's clarified underneath about people with learning disabilities as well, but I just wondered if, presumably that's taken from data. It'd be taken from data, that, yeah? Okay. Anything on page 2 then? On page, sorry, Peter.
There is the whole question about sampling, which we can come back to, please.
Right, page 3 then. You've got an 0800 number. Is that if you've got any questions or you want help, you've got to call a 0800 number or email. So the 0800 number, is that a free number?
Yes.
Maybe a bit of reassurance about you won't be charged for that call might be a good idea if that's what you're not going to be charged for. Yeah, there's a cost from mobiles, so from a landline. Okay. But also, presumably you're not saying to people they can go into any library or customer centre that the council has if they've got any questions. Is there anything? It's just the telephone number and the email. Because somebody may want a face-to-face discussion. So how are you going to address that? Okay. Are there any other comments on that page? What do we think about the consultation timeline? 15th of March to the 10th of May. It's quite tight, really, isn't it? I think that, especially when you've considered that you've got Easter in the middle of there. So, how are you taking account of Easter? Are you extending? Yeah, it's public holiday, so are you extending your timeline to account for public holiday?
We haven't done. We've got an 8-week period.
Chair, I was just wanting to explore a bit more about what might be the specific impacts of Easter. So we recognise we're predominantly not consulting with children, so the school holiday issue will become less of an issue.
What I'm thinking about is if you're a family member or if you're a carer, there may be already things that are happening around Easter that may impact on your ability to actually your time available to fill in the questionnaires, etc. So I just wanted to know if there'd been any thought about that, because usually if there are holidays and things like that, that's usually factored in. So I just wondered if it had been, because obviously if people are away or anything, then how would, you know, what does that reduce the time frame they've got? Okay, so that's just something to consider. All right, we get to the questions then, making more use of community sport, family, friends and neighbours. We've already had the question about question 1, but that first paragraph, it says an important part of the council vision is that we are able to help ourselves. Who is the we? Is it the council or the user? Do you know what I mean? It's just, yeah. Yeah. And again, you've got about strength-based approaches. Its focus is on the strength and assets of an individual. Well, would a person relate to assets? Yeah. It's just, it is very, the language that you're using is not very accessible throughout this day. You want to come back in?
Yeah, just on the an example of this approach, it does refer there to Mrs T using a local community lunch club and a coffee morning. I think it's just worth bearing in mind that some of your respondents might say, well, yeah, we used to have one of those, but it closed because of the cuts. So putting all the eggs in the community services basket is a bit dangerous.
Obviously, you'll be aware that the council are investing significant money in Community Plus, which is about growing community services of that type for people to be able to access. So we've talked this morning about making a link to Community Plus in terms of building community capacity so that we can have more examples like the one in the document.
Yes, I wasn't going to comment, but it was good to see that you are including community facilities such as libraries. Is that a recognition that actually libraries do play a part in providing social care? Right, okay. So the next page is question 2 and question 3. Anything on there? No. Apart from questions that are probably going to be
with the language itself.
Yeah.
I think with all of it, it would be just the language. It is councillor officer speak. We just need to change that into normal people speak.
So, may I say, Liz, I think going back to the aims and objectives, if you could manage to get things into a couple of sentences, and I'm not belittling what you're saying, that you might improve responsiveness. I could be wrong, but your aims and objectives, and sorry, I'm just really labouring my colleague's point that that it's a bit wordy.
Okay, then Adults Kirklees Council Resource Allocation System. Your title in itself.
So the question, do you agree or disagree with the proposal to change the council's resource allocation system? It would be useful to have a heading above, in the paragraphs above, which says, this is what we're proposing to change. Because you kind of search through each of those paragraphs and it's difficult to pick out, well, what is changing then? So therefore it's difficult to answer the question.
And you've got, I realise and appreciate it is a difficult subject to explain what it is. But you've got things like cohorts of service users, and there's been a review of the costings to address the current inconsistencies and provide assurance that indicative will be sufficient to meet needs. It is important that the indicative budget is regarded as a starting point for planning care. Well, planning care for whom? And as we focus more on cheap, we will work to enhance professional judgment to allow discretion and flexibility. It just, what does it mean for the person? That's, do you know what I mean? And I appreciate that what we're coming from is probably somebody who's not embroiled in the language. We're coming from a perspective of the user here. And if we're not quite seeing where you're going and the language that you're using, then are you effectively managing to get your points? But you want to come in.
Yes, and I think it's just a sort of general reflection that I think we agree, actually. And it's something, for example, the RAS section we have looked at this morning about let's simplify that word and make it clearer, actually what the differences might be. And I think we've got some wording that would do that. Our job is to, and this is a final draft and we've probably not quite got it right, but our draft is to do a final plain English look at it, and that's what we'll be doing post this. And I think what you've given us is strength to the elbow to be able to do that and clarity about some of that. So that's very helpful, and we will be doing that editing to try and put it into some plainer English and put it into the shoes of a resident and a service user to be able to respond to it. In addition, to say that there is an easy read version that's being produced, which will also help with that process too.
I just wondered, do you have any service users or carers who are involved in the discussion around the consultation process and who could help you to comment on the wording?
Not on the document, that document itself. Time hasn't allowed for that, but the easy read version is producing collaboration with people with learning disabilities. In fact, it's producing collaboration with MENCAP Liverpool. So there is that level of involvement that will help certainly with that sense checking and that clarifying and plain English that clearly needs to be done.
There is a view that don't have two versions, just have a simple easy read version.
Right, okay. Questions 5 and 6 then. Now, what impact does this change have on you? And you're talking about the resource allocation system. I think that goes back to maybe our point about we're not clear as to what you're actually asking. And so how does somebody know whether it will have an impact on them? And I think it's just about clarity of where you're going with this, don't you? Yeah. Kirklees Council direct payments then. Now, this is quite, again, it's quite thick, but the language here. And so it's, can you make this any easier to read? I think that's, you've set out how direct payments may be spent, which is good because you're setting out the criteria that people have currently. And presumably then you're going to set out, well, a bit more clearer, we're looking at this area and this area in that criteria. And all the rest of the criteria presumably is going to stay the same. You're just looking at a couple of areas on the criteria of direct payments, are you? Or are you looking at the whole criteria of direct payments?
What we're going to do is to develop a direct payments policy because we don't have a formal policy at the minute. So we work to the spirit of the law around direct payments, but we don't actually have a policy that we can give to people when they're exploring whether that's the right thing for them to do. So the intention is to do that. When we look at what are the things that we grapple with in terms of the use of a direct payment, it particularly is those two issues where people either employ a household member or where they deploy the direct payment as part of a holiday. And those are the two issues where we thought if we wanted to steer people and get people's opinion, those are the things that we grapple with most. So it's just to give a steer around that.
Are you asking anywhere in this document what people's experience of direct payments currently is and what suggestions they may have for improvement? Because you may be asking that of the focus groups, but are you asking that of people who are actually filling in the questionnaire without going into the focus groups? You know, what's your current experience and what would you consider would be an improvement on the system at all?
I think that's very helpful and we can add that in.
Yeah, the list of things you can't spend a direct payment on includes employing close relatives, so to provide care. So that's in the list there. Then step below, it says, a couple of paragraphs below, it says, well, you maybe can in exceptional circumstances. And then further on, you're asking direct questions about, do you think this should change? I think it just needs a bit of tying together. At the moment, the policy is that you can't use direct payments to pay a close family member to provide support. But we'd like your views on this, about the possibility of changing it, and ditto on holidays, just to make the flow a bit clearer, I think.
The law sets out that only in exceptional circumstances should you employ household members, but the difficulty is defining what is an exceptional circumstance. And I think, having had this discussion, we could pull that out more and say, how would you describe an exceptional circumstance, rather than asking people to comment on something that is essentially the law. I'd like to ask a question whether people feel it's useful to have those bullet points in around what you can and can't, or do members think it detracts and we could take it out? Take it out. Thank you.
I think it needs to be referenced to the fact that what the law is in terms of employing close family relatives and in relation to holidays. But then in the question 15, using direct payments for family members, the way it's phrased at the moment, it looks like the council now has an option of saying, yeah, we can introduce this, but what you're saying is you could only introduce it still in exceptional circumstances. So it needs to be clear that that is a rider on that particular point.
Sorry, I mean, it's probably inappropriate, but I mean, it was really just coming back to, because we are concerned about succinctness, but it was really about what is the target population and what is the sample we're looking at, because, it may well be, and I don't know how you're going to draw your sample, but presumably for this is an online thing, so that it immediately restricts it to the computer literate. And I wondered how you'd reconcile that with being representative, given that quite a lot of your users would not be computer literate. And then I wondered from the computer literate whom we going to choose, because yes, I mean the questions are important, but on the other hand, any survey is very much a function of its sample.
And just as a follow-up to that, you've got a lot of references to website addresses to read more information. And if you don't have access to that, are you saying in anywhere where people could go to get access to that? Do you know what I mean? Because you have a lot of references to, and I can understand why you want to give people the background as well. But it's just accessibility, that's what I'm asking.
Just to answer councillors, that you are right that open access surveys that are online are going to be restrictive for some people to participate, particularly in a consultation like this. And that's where there's a multiple method approach of the telephone survey and the focus groups. I think if you just did the online, it would be an issue. There is also the easy read and the hard copies available on request as well. But it is a challenge, and that's why there's a multiple methods being applied. Actually, my mind has slipped on the last question. What was the council's question? Yes, I was just going to make a reference to that, which is, the challenge with any document like this is to have it stand alone on its own right, and that's what we're talking about, succinctness, and it is difficult to get sufficient information in there so people can make an informed choice. Absolutely, language needs to be clearer to enable that. And so those references to links are for those that are really interested, but it should be able to stand on its own without people looking at those links if need be.
On the direct payments questions, would it be useful to know whether the respondent receives a direct payment, first point, and secondly, are there any particular reasons why you haven't claimed direct payment? Are there any barriers in the way that prevented you from applying?
And also what you're saying about is, do you agree or disagree with the council's proposed approach to direct payments as outlined earlier? And that just shows back to clarity of what your approach actually is, so that people can answer that question. But you said hard copies on request. And so how are you going to consult with existing service users where they haven't got internet facilities if hard copies are on request. How are you going to ask existing users to complete the questionnaire if they've got to request a copy?
I mean, I think that's a really good point. I think we can consider it outside this meeting, and we can think about how we offer some face-to-face support.
Sorry, I mean, I think there's the whole question about how you're going to draw your sample. You know, given the different constituents that you've got, and how within 250 you're going to get some notion of having randomised. Sorry, it's an observation, not a...
Okay then, so the 10, 11, 12 and 13 questions, anything on those? 14, 15 and 16. I think my pen had run out there. 17 and 18. Now then, 17. This is again, is to go to where you're going with this. Do you have any further comments to the proposed adult social care offer? And I wrote, what proposals? Because I hadn't got that from the context. Okay, so I didn't feel that I could answer that question if I was answering it, because I wasn't clear. By the time I got to question 17, I still wasn't clear as to where you were going with your proposals. Okay, so I think that just goes again to clarity. Are there any other points that people do?
Yeah, please, yeah, I mean, I don't want to labour it, but just on sampling, and it's having looked at the questionnaire, which is obviously important. Again, the sampling frame would be interesting to see for the telephone interviewees, for the workshop participants, for the focus groups, for the staff, and really to know how all that data was going to be made sense of, whether you intend to do these things sequentially and feed in information once you've got your questionnaire results, or whether you're going to analyse the whole lot simultaneously, or whether you're going to triangulate it. I think there are technicalities in there that, and I take the point, multiple sources of data are probably absolutely vital to what you're doing, but it's what sense you're going to make of it for the final report. Sorry, you don't have to answer that now, but I mean that's...
Give a reflection, and it's a good point, and always a challenge when you've got multiple sources of data, but that does give you powerful data as a result of that. We will be producing a single integrated report, so it will have all the elements of the consultation included in that. And just to give you an example, where perhaps there's a question in the questionnaire, those results will be shown for those that have responded to the open access survey, and for the telephone survey, which will replicate to very closely the open access survey. And we will have also discussed those sorts of issues in, say, the focus groups and the workshops with staff and stakeholders, and we'll be bringing out those perspectives under that question as well, to give a view across the whole piece, what different groups think about that particular question and issue.
So you'll use your questionnaire response data as triggers for the other things that you do? Yes.
As a structure, yeah.
And I mean, some of these things lend themselves to statistical analysis, you know, Likert scales and the like. I mean, do you intend to use SPSS and convert this to numbers, or what?
Yeah, the questionnaire data will be shown as percentages. We'll be looking to analyse it by different types of residents and service users, where there's a question in there about what the type of respondent is. There's questions in there about qualities in particular. And one of the key reasons for the consultation is to assess whether there's an impact on different groups of service users and residents. So we'll be looking at the data and reporting where there are possibly differences in opinion that stand out and have, are, for want of a better phrase, statistically important differences.
But is there surely, given the way you're going to administer it, is there still not a problem about randomisation, about including everybody, given our diverse population?
Yes, so I mentioned with the telephone survey, for example, that's where we can inject representativeness to make it demographically representative of Kirklees. It is only 250. Limits of budget mean that you can't go higher than that. But we certainly can set quotas so we know, for example, that we are interviewing X% of women and X% of men, just as a crude example, so that not everybody that responds is a woman or a man and therefore would be biased. So it's that we can inject that level of representativeness. You talk about randomness, which is a principle of surveying that allows you to say that anybody had an equal chance of participation. And we also we purchase a telephone list that's linked to the electoral register. So and then we draw from that at random the phone numbers that we call. So there is an element of that as well.
And what if you get a very low response rate to your questionnaire?
To the online version of it. Well, that again is where the telephone survey is first of all, we need to try and, through good communications and promotion, and by having a plainer document, that's where we want to help try and get as big a response as possible. But also that's where so with an open access consultation, there is a little bit in the lap of what, because as to what happens in terms of who responses. But that's where you do your targeted stuff like the telephone survey and the focus groups, so that we are definitely getting some opinion and some views in response to the issues that we're trying to consult on.
On the telephone survey, a lot of people don't answer surveys on the telephone, so I think you need a balance. Stella, did you want to come in on that? Yeah.
Just coming on from that, the focus groups that you mentioned, you've said just 5 small focus groups for these service users, so not potentially people that will be coming into the service or new people will be coming into the service. How have you decided where you're going to locate them, or have you decided where these focus groups are going to be? You want to launch this consultation as of the 15th of March, which is around the 13th, so they're already in 2 days' time, so you must have some idea of where you're going to have them.
Yeah, so we have a very clear idea about the process for recruiting people to participate, inviting them to participate, which will be with and through local providers, local stakeholder organisations that have links with people that are currently service users, and we'll be using them as partners to help us recruit and invite people to participate.
Why have you shared that information with us in terms of where these focus groups are going to be?
Sorry, in terms of the location? We haven't set that. They're going to be in about 6 weeks' time. We haven't set that yet. The priority's been trying to get the document right. That's a detail that is pretty easy to work out, to be frank. The challenge is working with the providers which we're starting to draw those links now, to identify people, to encourage them to participate, and then we set dates and venues after that. It's not an open invite. If you have an open invite, you can't control the discussion very well. It's a targeted invite and a targeted discussion.
We appreciate it's a targeted discussion, but we appreciate you're on a time scale here, but maybe if you could share with us the locations and the partners that you're involving in the invites to the focus groups, I think that would be helpful for us. And we can email, if you send it via email, we can email that round to the panel for comment, okay? Just so that we're assured that there is groups across Kirklees, and that we don't think that there could be other groups that you could have asked, because people do have knowledge of groups that could possibly be asked. Do you want to come back in?
No, I mean, we were just saying it would be helpful if we could see a revised questionnaire.
Yes.
I mean, not to be difficult, say, but
yeah, I think yes, definitely a revised.
Given that we've banged on about it,
I know, definitely a revised questionnaire as well. Yes, but can we just turn to the in the report, the stakeholder list that we've got? We've sort of got onto that now. There's a couple of questions on here I think perhaps we would have. You're not, when you say in the general public, you've not mentioned social media at all to say about your consultation and where to go for that. So I'm presuming that would be what you would do. your postcards and flyers to the general public, I'm asking where you're going to put those out to. How are you going to approach that? And also your members' briefings. When are you going to be doing those members' briefings?
I think there is a clear timetable being worked up, and there are a number of different approaches to consultation. So I think it'd probably be better if we could get you a copy of that timetable that will include everything.
That'd be very useful if you can, please. And also where you're going to send things to. I think that would be useful as well, so we get a clear idea. That your briefings, presumably to councillors and MPs, will be in a timescale that is at the start of the consultation and not in the middle or towards the end, bearing in mind timescales in this. Yes. And that all communication will be given at an early opportunity. Yes.
Just to throw a spanner in the works, how important is this the date? Because I'm seriously considering the fact that date needs to be pushed back, and we need to get some paperwork ready and actually see what's going on before you actually approach the general public about this.
I think it's really important that we get it right. So if we take away and reflect on the comments that have been extremely helpful to us, and then we'll communicate with you the outcome of that, what we feel we can achieve, and whether, because these are the drafts, we've been continuing to work on them. So if we get back and confirm with you, but it's something that we'll consider, because the importance is that we get it right. Otherwise, it will undermine what we're trying to achieve.
Yeah, just a point on the About You section, question 32, which is the postcode. How necessary is it to have the full postcode? Because I'm just conscious that some people get put off by putting their full postcode on because there are some quite sensitive questions in the About You section. So do you need the whole postcode or?
Ideally, yes. And you're right, people do get put off. And to be frank, they either put it in or they don't.
Right.
So we try and reassure as best we can, but it's helpful to have that information if we want to do some analysis by geography, which I think here in the feel of the room is something that could be useful as well. So we have to ask it, and you hope that typically about 80% of people in our experience will give you the postcode.
Right then, can I summarise then, and if there are any other points you wish to bring in on the summary? So it isn't ready to go out, I think that's what we're saying. And we appreciate that you realise that you're still in the drafting phase. We would like it right before it goes out to the public, and therefore we would like to see your questionnaire again. We'd like to see your methods of communication, your focus group proposals, how you're going to put your postcards and flyers out generally, how you're going to allow service users to interact with the consultation where they don't have internet facilities, and also your member briefings, when those are going to occur, when you're going to schedule those in as well. Okay, so I think does that generally summarise what we're asking for? And we obviously we don't have another meeting for a few weeks, but we'd be prepared to look at things via the email and comment. We're perfectly used to doing that. Okay, all right. So we will do that for you, and we will then report at the next meeting what the outcome of those conversations have been. Okay, all right. Thank you very much for that. We will just pause while we move to the next item. Thank you. Okay, this is agenda item 6, the Kirklees Safeguarding Adults Board. We've got representatives of the board here today. So if you'd like to say who you are before you speak. Do you want to give an introduction to your report at all? It is the 16-17 report, even though we're nearly in 17. Yeah, if you could explain that, please, because yeah, we had a few questions around that. So if you could explain that as well, please. So do you want to introduce yourselves and your report, please? Thank you.
Chair, thank you. Hi, I'm Saf Boot. I'm the Head of Safeguarding Quality and Performance in Adult Social Care.
Yes, and I'm Mike Evans. I'm the Independent Chair of the Kirklees Safeguarding Adults Board. And some of you who were here last year will remember I brought the annual report last year and the strategic plan. It's partly my fault that it's at this late stage. I did make the offer that you could have held Scrutiny out in Cambodia when it was actually scheduled. And you can get cross with the officers that turned down that offer. But I was on a cycling tour across Cambodia into Vietnam. So it was unfortunate, but I hope I can bring you a bit more up to date with some data as well. Okay. So in terms of this report, you're right, this is the year that takes us up to April 17. And during that year, we identified, and I put it in my introduction actually, we identified 3 particular areas that we felt we should be focusing on. One was the use of data. It's always a challenge for safeguarding boards to make sense of data. Now we have a subgroup which is very well chaired, and so the data that comes to the board is filtered and helps us focus our strategic discussions. The second thing I'd say is that the reports produced in Kirklees have the added benefit that whilst the data people access the data and put it together, there's a very clear discipline here that it's an operational manager's responsibility to put the narrative against the data. And I think that's a very important point because that doesn't happen everywhere. In some places it's almost left for those people crunching the numbers to try and make sense of them, and that would not be right. So we're very clear that we want operational analysis of the data. And we now have a dashboard which, to bring you up to date, was presented at the last safeguarding board. There's more work to do on it because we still want to get more better analysis of the NHS data. The data that comes through the local authority is of very high quality. But we are getting there, I can reassure you of that. We don't let go of that one. Making safeguarding personal is a very strong theme here and nationally. And I mean, you've heard me say this before, but it basically means nothing about you without you is the mantra that goes with it. And I think that actually speaks for itself. We have just completed the challenge session. Every year we have a challenge session where we ask the agencies, well, we require, to be fair, the agencies who are part of the board to attend, and I meet with them with some support, and we put them through their paces in terms of where they're going. Now this year there is a self-assessment around making safeguarding personal, so we asked them all to complete that in advance of the challenge session, and then the questions were geared to challenge some of their responses. Just to let you know, I was speaking to somebody today who's just pulling together the spreadsheet which gives me the summary of those conversations. I've still got to meet NHS England. I'm doing that by telephone in a few days. In summary, making safeguarding personal is getting traction here in terms of practice. The recording underplays the success. There is more to do for people to actually record what they are doing in a way that reflects some of the good practice. So it's going to stay on our agenda, making safeguarding personal, through into next year. We're just about to start work on the annual report finishing April 18. I get my years right. And I promise you'll get it earlier than this next time. Okay. And a major thing for the Safeguarding Adults Board, which I'm particularly pleased to be part of, is the way we've made the board much more outward-facing. It's all very well to say you've got a board here which provides, to use the language of this group, scrutiny over the way the partners undertake their work. But we need to do that in a way that's even-handed, and we need to do it in a way that we recognise we can't do it on our own. And for that reason, I'm very pleased that the Safeguarding Adults Board has played a major part in driving the collaboration between the other strategic partnerships. And if you ask me what those are, I include the Health and Wellbeing Board as a strategic partnership in my thinking, although it's a subgroup of the Council. Right? But the other two clearly are the Community Safety Partnership and the Children's Safeguarding Board. So I meet with the independent chair of the Children's Safeguarding Board regularly as well. And that work, to be perfectly honest with you in Scrutiny, that work has had a bit of stop-start about it. And I think that's understandable given the things Children's Services in particular have had to tackle over the last 12 months. But we're getting it back on track. We contribute. It's important that members of the Safeguarding Adults Board feel it's their responsibility to get engaged with work on domestic homicide, domestic violence, hate crimes, a whole range of things which obviously impact on Safeguarding Adults but may not be totally the governance of the Safeguarding Adults Board. So we want to be outward facing and collaborative, and we will keep that going. We created, I mentioned this last time, but it's just reinforcing it, we created an infrastructure to support the board. There are too many boards around the country that have a cast of thousands and achieve nothing. We have a tight board. We don't want lots of members, we just want the key leaders on the board. But in order for that to work, there's got to be an infrastructure, an engine room behind it to do the work, and that's our delivery group. And the delivery group is chaired by a senior manager in the NHS who acts as my deputy on the Safeguarding Board. So we always have a session at each Safeguarding Board picking up issues that the delivery group bring to us. And the delivery group really have responsibility then for focusing on what the work programme is, making sure that where there are subgroups established that they have clear remits in terms of delivering the work programme. And where a subgroup doesn't fit, they set up a task and finish group to do that. And we're very clear that this is a partnership hosted by the local authority, the Safeguarding Board. It is, and for that reason, it's important that all the partners play their part in contributing to that work, including chairing some of the subgroups. Okay. You'll see in the report, it's on page 6 of the report, I don't know which one it is, I'm very pleased to see the attendance levels we get, and most people are there 100% of the time. Okay. I'll put my hand up and say, next year when you see it, you'll see I haven't made my 100% because I was in Cambodia for one meeting and my deputy chaired it. So I'll give you early warning of that one. Okay. One of the things we've done in this annual report, and we're going to develop it further in the next one, if you turn to page 8, it's just an example really. In the past, we've tended to just talk about key achievements. You'll see there's a section under key achievements there that says "and next." And the next one will say "and how." So it'll go key achievements and next and how, what we need to do, what the constraints are. And I think one of the things every council is dealing with, and you'll no doubt be dealing with quite strongly through scrutiny boards, is how services are delivered at a time of austerity. So it's really important that we recognise that and encourage some smart thinking in there in terms of how those ambitions are going to be delivered. Okay. And not a lot more to say really. The text is all there. I really should stop talking and answer questions. Just to say, the report you've got, and I pulled it off as well, is missing some pages. If you and we could, I've already raised it, and they're going to put that right for you. If you click on the link in the report for the strategic plan, you'll see the missing pages, because actually there's some parts of the work programme are missing, but they're in the strategic plan. Okay. And just to bring you up to date with the data, it's getting busier. And the figure in the report, which kind of shows the year-end position, they're now talking about this year 2,355 inquiries, of which, reassuringly, 2,305 are now classed as legitimate Section 42 inquiries. So that really tells us that those people referring in, and some of the impact in terms of the awareness raising we've taken from the board about what is a legitimate safeguarding inquiry, is working. So we are much closer now to getting people out there in other agencies understanding what is legitimate to refer in. Okay, thank you.
I'll open it to questions then. Do anybody have questions on the report, Peter?
Yeah, I mean, just
to,
sorry, just to come back to what you said at the beginning, Mike, really about the trustworthiness of data, and you're not to oblique reference to the NHS, and I just wondered how much of a handicap that was.
Well, I'm going to be fair to the NHS now. But also put some challenge in. The NHS don't measure data in the same way as the council does. And the reason for that is that, by and large, the way in which they measure data has to feed the national data set for the NHS. Whereas you've got, in councils these days, some of that impetus is less onerous for feeding the beast, although it's still there, but you do produce local data which isn't necessarily always fed in. I do have this conversation quite a lot within the council data as well, to say, look, I still want to see this bit even though it's not being asked for nationally. Okay? So we do that. We're having those same conversations with the NHS. The obvious thing is, in my working days, they used to be called serious untoward incidents. They're now called serious incidents, aren't they, Richard? Yeah. Where the NHS have incidents which they have to report and investigate, and it could be anything really, but it's something they need to investigate. The conversation we're having with them is we want to know about them, and we want to know about them, and we want to know how many of those you feel fit the category, or we feel fit the category of being equivalent to a Section 42 investigation, a safeguarding investigation. I think some of our NHS colleagues actually get that, and some don't. So we haven't got it universally yet across all the providers, but we haven't given up, because it's a bit like the figure I gave you. The number of people who contact to say it's a safeguarding incident is one number. The number that actually turn out to be legitimate safeguarding investigations is a lower number. Well, serious incidents, the same argument. We accept that a lot of serious incidents will happen in any institution, and certainly in hospitals. But how many of those were avoidable in terms of thinking of it in safeguarding terms? Okay.
Yes, my question's on deprivation of liberty, so that's page 78 in our report, page 39 on yours. The increase in the numbers from 973 up to 1127, that's obviously another significant increase. So I just wonder what the implications of that was in terms of staff resources. And the second part of the question is, do you have any provisional figures for the year just about to end? So has that increase continued into this year, or are things levelling off? Thank you.
Thank you for that. Yes. Where that rise started was following a Supreme Court. Excuse me. Could I get a drink of water? Supreme Court judgment, known as the Cheshire West judgment. And that basically said that the law is fine, but the interpretation of the law is not being followed properly. And thank you, Richard. As a consequence of that, a greater number of people had to be referred for under the deprivation of liberty legislation. And if you want an example, one example would be somebody in a hospital with dementia who won't settle and keeps trying to leave but needs to be there for their own safety. So in the past, those things wouldn't have necessarily been seen as abnormal and would have been managed outside the legislation. And there are various other sort of social care settings as well that had to be tightened up, particularly in the area of learning disabilities, because it was a learning disabilities case that the Cheshire West judgment was about. So that led to an increase. And that led to a position that the Court of Protection suddenly was overwhelmed. So you've got all parts of the system under pressure now. To answer your last part of your question, it's fairly stabilised now. That peak has kind of happened and it's gone more stable. So the Association of Directors of Adult Social Services produced some guidance for how to manage the pressure within councils. And that essentially means that there's a tool you can use to prioritise those cases. I'm satisfied that I ask this question frequently, because I know that you've got to be really careful in this area. I'm satisfied that Kirklees is properly utilising the ADAS tool to prioritise those more urgent cases, i.e. those people where if you didn't do a deprivation of liberty assessment, the risks would be untenable. Okay.
Can I ask about your partnership with Children's Safeguarding as well, please? How is that cooperation progressing? Because decisions in adult safeguarding can impact on children's safeguarding and vice versa, decisions across the board. So I'm just wondering how that is progressing and in what form it is taking, the cooperation between the two.
Well, clearly there are some areas that we collaborate on and it's documented. For example, we contribute to the work on child sexual exploitation. And we contributed in a way that we've successfully argued that there is another domain in there called young people's sexual exploitation. And the police fully with us on this one locally. For all sorts of understandable reasons, CSE has gained traction across the country and here as well. So it has to be a piece of work that any children's safeguarding board would need to address. I've got personal experience of when I was working in another local authority, when I was actually director in Manchester, of a sexual health clinic nurse contacting us to say, I'm worried about young people being brought to the sexual health clinic to get their contraception, and they're of low intelligence and they're ex-care leavers, many of them, and they tell me they're going to spend a few hours in a hotel. That led to a specific investigation. To have an arbitrary age barrier for me seems silly, and it's an obvious area for collaboration because the same perpetrators may be involved below and above 18. So that's one example of where we've been quite overt in trying to make sure we influence the work. As I say, I do meet with Sheila, and we are committed to two things really. We're committed to two very important things. We're committed to the idea that people live in families, and just because somebody somewhere some years ago said there had to be separate safeguarding boards for children and adults, And there is some logic in that, but we shouldn't allow that logic to make us siloed. We've got to work together. And we're keen very much to collaborate and really support each other's work. One of the conversations we quite often have is the importance we need to make sure the boards have in challenging our hosting authority. It's very easy, and there are examples where that part of the challenge and scrutiny of a safeguarding board has got diluted, and we won't do that. Okay.
My other question was on serious case reviews and the learning from the serious case reviews. I think you had one that probably come into this new report, and presumably you will be putting in information about the learning from that. But how does learning from serious case reviews, how does the Safeguarding Board ensure that that is put in place throughout the services, and that services discuss between themselves how they're going to improve methods of communication, etc., and procedures?
That is a really good question, and it's one that's always there for us, because again, we have a subgroup which deals with safeguarding adults. I must correct you, Chair, they're called Safeguarding Adults Reviews. They changed the terminology for adults, but it's the same thing. Well, it's not quite the same thing, because the guidance actually says we must be proportionate in the way we carry out these reviews. So we don't have a fixed model. We look at the situation in detail and say what's the best way to achieve an outcome through a review for this particular case. The Safeguarding Adults Review subgroup is chaired by Superintendent Khan, Oz Khan, and I went to ask him to do it, and he agreed to do it, and he does a stunningly good job. Two things really. You're quite right. You've got to capture the learning from a serious case review. It loses impetus if you see a serious case review in isolation, because I think you were hinting at, it's quite common to find, if you look at a number of serious case reviews, safeguarding adults reviews, and you look nationally as well as locally, some of the themes are very similar. So in terms of capturing the learning, then you start to think about what are the common areas. And Mental Capacity Act was mentioned, that's one example, right? So one of the things that we do is we, in Kirklees, and these were going on before I arrived, and they're really good, we have networking events. And the networking events can have well over 100 people attending from partner agencies, voluntary sector, and we run those network events. They're open, and they're very much driven by some of the learning that needs to come out of tragedies. We've had some, last year we had a really good networking event which was about doorstep crime, and Trading Standards did some wonderful work for us then. We were going to have one during the snow, and we had to cancel it, and it was about DOLS, Mental Capacity Act. It was about that stuff. We want to have another one again about making safeguarding personal. So we tend to pick up, rather than they all have action plans, and you performance manage it, and you tick the box to say this procedure is in place, that's it. But you're talking about the learning, you're talking about the culture and embedding the changes, and that's the way we do it.
How is data collected in terms of safeguarding? Might be an obvious question, but and serious cases. I mean, I sit on the CSE panel, and there's concerns of, and we've discussed about when there's people that commit suicide or taken life, and that information doesn't come in until probably 6 to 12 months, and that's the only way we can collect that information. We use that data. I'm just trying to understand how we collect our data in terms of the safeguarding board. Is there a time capsule or a time lapse that we've got, and are we always working in with 6 months old kind of information, or is it now?
Thank you, Councillor. That's a really good question. I think With regards to the data, the ethos that's used within safeguarding is that it's about the safe and effective flow of people throughout the entire pathway. So the data is pretty much linked to the work that's done day to day by the safeguarding operational team, and that's now it now consists of a set of safeguarding consultants. What we've done is we've moved into new ways of working, so our social work teams now take responsibility for the whole safeguarding pathway. So whilst there isn't a similar sort of time lag as you described with some of the other areas like child sexual exploitation, what we do have is that there's a series of events that need to take place, and that there may be a slight delay whilst those events take place, such as investigations or strategy conversations. Once those events have taken place, there's a clear ask that that data is then reflected back in the system. So one of the sort of trigger points that we might have is we might look at when the last strategy was done and whether the system reflects what was discussed as part of that strategy, and that information is fed back into the team so that they're consistently on top of that.
Another question, sorry, not following on from that, but in the report you talk, I did the counsellor training as well, so are we to say all counsellors will be getting the new counsellor training as well this year around? What was the uptake like in terms of counsellors? Did all counsellors actually attend all of them? Because I think with safeguarding it's one of those essential ones. I'd probably say you must be at it.
I mean, I can only talk about the session I did, and it was really well attended. And what I'd say is it was really well attended before and after the meal. So rather cheekily I say that. But really, I thoroughly enjoyed it. I'd love to do it again. I thought the elected members were really engaged. I did it jointly, even if there was children and adults who did these joint sessions. We had presentations, around hate crime and the radicalisation agenda, and I felt it was a really good example of demonstrating how strategically we work together. So I think people got something from it, and if you want to do it again this year, I'd be very pleased to get involved.
Yes, please. I think that would be definitely yes, please. And your networking events, they sound like something that us as elected members would be something that we'd be really interested to get involved with, and also be able to kind of cascade that information out to the constituents as well. So yeah, thank you.
Are there any other points that we wish to raise? No? Thank you very much for coming today, and we look forward to seeing you again in 2018. Thank you very much. The last item on the agenda is the work programme. The next meeting, we'll be looking at that in more detail, and our next meeting is the 10th of April 2018. So thank you very much, everybody, for attending today. Thank you.